As a doctor in Western or allopathic medicine, I wasn't trained to appreciate fully how important a role food played in our health. So, most of what I knew about the impact of food came from growing up in a culture where Ayurvedic medicine was quite popular. But now we are beginning to see a growing acceptance and realization that food and nutrition are vital components of illness and disease. I spoke to Dr. Pratima Singh about this topic when she came to our Mental Wellness Mastery Summit last year. Now, Pratima works as a psychiatrist and a functional medicine specialist and shares passionately her experience and understanding of the role of food in ensuring good health. So I invite you to listen to the conversation in full. I started by asking Pratima how she got into functional medicine as a psychiatrist.
Not many people might know what functional medicine is. I definitely didn't know about it myself. But I think it is something that I've arrived in my search for a more holistic model of treating health, not even mental health, but just treating health in general. So the background really comes from India. So I was born, brought up, and I did my graduation in medicine in India, where I was exposed to many holistic health care systems, and especially Ayurveda, where everything began from gut health. There was really this belief that you do not hone in and focus on the ailment. You do not match the ailment with a drug, but you looked at the whole person and also how they were interacting with their outside environment. And one of the first things an Ayurvedic practitioner will want to look is your pulse and your tongue. The tongue is thought to be the window to the alimentary canal. And literally begin the exploration from there. The next question usually is about the bowel movements. Yeah, it is irrelevant whether you have arthritis or if you have depression. So that is the environment where I was training in this very conventional biological medicine. But luckily, none of my patients were as narrow-sighted as I was. They were exploring other things. So I was hearing about these other things that were helping. What brought me to UK was really my passion for psychotherapy training, which again was, really interesting. I got lots of psychotherapy training in Maudsley, where I did my higher training. I used a day a week of my entire training to explore and get, in-depth experience of psychotherapies. But I still felt like something was missing. So, and during my higher training, it was actually a leadership and management fellowship where the penny dropped for me. And because here I was tasked with, leading a physical health sequence in a trust. And what I found was we were incentivizing, we were paying clinicians the trust money in order for them to improve the monitoring. And it is in one of those presentations where, I was asking people, so how is this going to benefit? And the discussion boiled to, we will continue to monitor until the person develops diabetes and then we treat it. And for them, that was prevention. And I must say that really shook my world a little bit. And I thought this can't be right when, what evidence is telling us is that our patients are dying 15 to 20 years early. And I must say that I was not really aware of the blind spot, for myself or for the teams that I was working in. But, as these things happen, many different things happened at the same time. I became more and more aware of the discontinuation and the withdrawal phenomena. In fact, that's how I met Rani. We both crossed paths because of that common interest. We visited the Bristol Tranquilizer Project together. My attempt to talk and teach about nutritional interventions in psychiatry is my small contribution to start the conversation and begin the awareness. There is so much more to this holistic model than nutrition, but it's a fantastic place to begin.
Yeah, absolutely. And how is that going, may I ask?
It was very frustrating to start with. As you can imagine, I was, a young consultant in Maudsley who wanted to, kind of change the world. It seemed all very natural to me. And as these things go, all the roadblocks that I experienced have been immense opportunity for development. I realized that, the gung-ho approach and just kind of throwing evidence in the face of clinicians who are used to practicing a particular way was not a very effective engagement strategy. So, what I committed to myself and to my patients is that every appointment that I have will have, maybe 5 minutes, maybe 10 minutes of a nutrition and lifestyle focus. And I have done that since the day one of becoming a consultant psychiatrist, which is now, close to about 7 years. And that has gone fantastically. What I have also found is that there is a huge uptake. I have not stopped being invited to another mental health trust. And really I don't even know from where these, the awareness is spreading, but, I have spoken to a bunch of anesthetists who were curious about the topics. I have spoken to many GPs, obviously mental health colleagues, to Mind. And I basically just go ahead and present this, hoping that it will, raise awareness and change practice. I would say it's going fairly well.
In terms of kind of mental health itself and mental health issues that you experience in your day-to-day work in your clinics, I mean, what links are you kind of seeing with nutrition and diet, and how do you kind of engage in that conversation with your clients?
The first thing I would say is that it has been really humbling and demystifying for me, even though this is something I'm interested in and I believe in. And I will be truthful that, first when I started to do this, I became becoming aware of my own biases. You can never predict who will adapt this, accept this, and run away with it. But I think what I have learned is, food is so much more than food, Suraj. Like, especially in psychiatry, it is not something we can break down to nutrients and macronutrients. Food has got so much meaning in mental health. It means comfort, it means nourishment, it means self-care, but it is also rich with so many memories. So what I passionately love is that it's one of the few things that we have in common with the person in front of us, that we can quickly relate to them. Obviously we have many other things common, but the boundaries of clinical practice does not allow you to share a lot. But food and interest in food, my patients love curry more than I do, I've realized. So it can be, it's really been very humbling. But what I also find is that, how food can become a weapon of abuse, of neglect, and how addictive food can be, and more so, how it can really affect the things that you're treating with. Just to give an example, I find that many of my depressed and anxious patients are on a roller coaster of withdrawal from one of the uppers, and this could be sugar or nicotine or caffeine. And, just the patterns that I've observed now, having spoken to like hundreds of patients about how they eat, I'm just shocked about how common it is to just go without eating for long periods of time, fill them with all these uppers, have that one meal, which could be okay, and then this long overnight fast. And when you overlap that kind of eating pattern on top of the presentations, it completely makes sense why the patient has got panic at night, and why they get jittery at that 10 o'clock, and why they are reaching out for that sugar. So one of the beautiful things that happen when you are developing a relationship with your patient and getting this data, and you're overlapping, they can see from themselves, they go away and start making the first change, come back, it really engages patients. For some of my patients, they have actually been angry. They have come back and said, I've been coming to the mental health service for 20 years. Why did nobody tell me this before? And I said, this is a start. I said, we did not know this ourselves, and we really believed, or we like to believe as, psychiatrists, that we were outsourcing your body to the GP. So we've got 10 minutes for you. And, the idea of now talking this together is for, everybody who's working with you to look at this closely. I always have some patients who tell me that this is not something that they can do. And then we kind of negotiate a place, how well I can help them to be given that limitation. And usually I find that things always change a little bit, sometimes more for some patients, sometimes less.
Are you finding in your practice, Pratima, that by following that empowered route, you have been able to reduce your dependence on the prescription pad as a psychiatrist?
Yeah, I think that's a great question, Suraj. So I think I really came from a place where I was a very conservative prescriber anyways. And I think that really came from, the excellent training I got in one of the units at Maudsley called the Affective Disorders Unit, where we looked at patients with treatment-resistant depression, complicated anxiety disorders. And so patients basically reached there when nothing worked before. And what really happened at that unit is that you just learned to do the things properly. So you would find that patients would have had tried like 3 different medication even at the level of primary care. None of them at therapeutic doses, none of them long enough, none of them withdrawn properly. So we were mixing the discontinuation properly. And what I learned to do in that unit is to take that eagle-eye, thorough approach, so that you got the best out of whatever you use. And I have tried my best to take the same kind of discipline in my day-to-day practice, where I try to not add anything unless I have understood in depth about what needs to change. So what would often happen, and some of my patients will tell you that I literally tell them that the medication will come last because I need to understand a lot more things before we can come to medication. And, as you have said, often I find in my hour-long conversations that by the time they reach there, the person does not want to do anything about their medication because they have seen or we have discussed, 5 or 6 different things that could be very pertinent. But I'm passionate about judiciously using medication, not as the first resort, but after we have kind of looked at things more holistically. And if we are using it, having the expertise and the art of knowing how to use it for the shortest period of time in order to avoid complications. And that can be really difficult, as you know, how the mental health services are set up, where there is so much disjointed care, where patients are going through these different parts of the systems. And sometimes at the point of discharge, I worry about, the patient just remaining on this long term. And, this is what has made me feel very passionate about remaining in community psychiatry, because I feel like it is absolutely the right place for that continuity of care. And the introduction of the integrated health system. So, for example, in my current role, I have a fluid exchange between the secondary care and the primary. My GPs write to me directly. They don't even have to refer patients to me. I'm the same consultant for the primary care health team, for the secondary team, and the GPs. So, there is that continuation. And I think we need more of those interfaces to do good medicine, especially to avoid prescribed harm by, kind of letting people remain on medication, especially as the only interventions. But, there are many ways I try to kind of bring this in my practice. I'm always on a lookout for opportunities. So a couple of years ago, my trust introduced physician associates. I quickly snapped one up, trained her into, she did a fantastic job. So every person coming in our mental health clinic for a physical health check was not getting just the monitoring, but they were actually getting interventions. They were getting nutrition advice, they were getting smoking cessation advice, they were getting cancer screening, signposting. So actually meaningfully intervening to change the dial about their cardiometabolic risk and follow them through. So that has been a great advantage. Another example would be I'm in discussion with my occupational therapy about how to convert what I can do one-to-one in a more of a group setting.
Coaches, healthcare professionals, therapists who are working with people with mental health issues, who may or may not be on medication. So how do you think this group of professionals can push forward this understanding of how important nutrition and diet are?
Yeah, I'm really pleased you asked this question because, people who have heard me talk on other platforms before will know that one of the things that I always say, that in doing this work, one of the most useful training that I had, of course, apart from the medical training, was my coaching and mentoring training from the London Deanery that I did as a trainee. because I think, especially as clinicians, and I think this is more applicable to doctors, I think our psychologists, coaching, nursing colleagues are much better at this than we are. We are trained to kind of give advice, and we believe that is what will work. Whereas, like you said earlier, nutrition is a different ball game. I akin diet and nutrition to more like religion. Yeah, I think it is interwoven in our identity more than we might be aware of. So it feels very difficult to change, because how we eat can sometimes have intergenerational kind of effect. So coaching, I have found, is one of the most useful intervention, and you'd be pleased to hear that actually Institute of Functional Medicine realized this after doing this training for over a decade, that health coaching is key for change. Because everybody knows it. Like, I'm sure, Suraj, you know that you need to eat better and exercise more. I definitely do. But are we doing it? So, again, what the things and the roadblocks are no different whether you are a patient or not. I think the roadblocks for the patients are just 10 times harder by virtue of their mental illnesses, by virtue of medication that might sedate them, make them tired, or give them, additional reasons. So health coaching and that compassionate, non-judgmental, supportive, problem-solving approach where the agency is coming from the patient rather than a so-called expert is absolutely key. And I'm very pleased to say that in my 2 days of functional medicine, I've just, paired up with a health coach myself and a nutritionist. And I always say to people, I am a very expensive health coach, and I'm not really that good at it either. So I very much see this as a team role where my plan is to, develop the interventions and the high-level strategy, but it is my health coach who then makes it happen. So I think my wish would be that, if we don't have health coaches, I would definitely want health coaching as a competency skill for all our community psych nurses, our social workers, our occupational things, and for this change to actually happen.
I asked Pratima if there is a healthy and balanced diet that she would commonly recommend to her clients.
So, obviously when I started out, like, many people, I was very keen to find, I fell into the trap of that, super nutrients or that superfood. But, the number of times that I returned to look at the evidence, I was terribly disappointed and at times very confused, because when you look at the vast body of single nutrient research, for every study that supports one thing, you will find 5 studies that don't. So it's very contradictory. And I think that mirrors the patient's experience, where one day in the metro, they will read that the coffee was going to make them live 100 years, and the next day it was going to kill them instantly. And I think, so I was very aware that that is where the patient was coming from. And, partly it was really successful marketing. As you can see, that it's really hard to pick up anything in a supermarket that does not have a hidden health claim message. So I really looked carefully at the evidence regarding that. And I think the universe conspires to support you when you are, kind of on the right path. And I think that's what happened for me around 2013 when I started to get, deep into this area, that some of the first properly conducted randomized control trials started to come out. So it was from 2008 that we started to see some of these studies. But really, I think the credit to give some credibility to this conversation began with Professor Felice Jacques's trial from Australia. And at the same time, there was another trial, the Alchemy trial, also from another part of Australia. And what both these trials were doing in very different designs was basically looking at whole dietary change. The other thing that they did is they looked at, they didn't look at this, kind of unhappiness, clubbing all sorts of depression together and then presenting. They took the proper unwell patients. So they took patients that we would see in secondary care. These were patients from moderate to severe depression who were already on some kind of treatment, and what they added was the Mediterranean diet. Yeah. Now that really appealed to me because, just breaking food into different nutrients never made any sense. We understand very clearly from research that nutrients work synergistically with each other. How a nutrient work on its own compared to, that beautiful synergism that exists in nature. Is not the same than taking 12 different nutrients on their own. We also know that single nutrient approach can lead to imbalances. So, for example, taking too much zinc can, make your copper go low, vice versa. And that, the nutrients were not really, just because they were not regulated like pharmaceutical medicines, they were not that innocent. People could get really unwell and sick. And one example that I always give to patients, that if you have a genetic defect called as a methylation defect, where you have single nucleotide polymorphism in the MTHFR gene, then even taking some multivitamins off the counter can make you feel really sick because you do not have the biology to metabolize it in the same way. So coming back to your question about what are the top few things we could do, I think if we are going to be evidence based, I think one thing that the evidence is telling us that you really can't go wrong with the Mediterranean kind of diet. But taking the research a bit further, when the benefits have been explored in a more broad way, because why we don't live in the Mediterranean, why must the whole world eat like the Mediterranean? What they have found reassuringly, that the components of the traditional diets that have been associated with lowered risk of depression are the same. And these includes plenty of multicolored vegetables, a bit of fruit. If you're eating grains, eating them as whole grains in their least processed form, reduced processed food, reduced sugar. So, whether you are eating the Norwegian diet or the Japanese diet or the Mediterranean diet, as long as these common components are present, it really did not matter. And they go so far to even compare that. So when you look at the gut microbiota and you compare that with a vegetarian or a habitual omnivore, they find that even the meat part of the component does not play, as long as the diet is rich in these components. So my top advice would be, introducing your patients to the Mediterranean food pyramid rather than the food pyramid that we have from our dietary guidelines, and emphasizing, bringing in components of the Mediterranean diet. So what I do in practice is that I will never ask patients to stop eating and start eating, because then that is very akin to the fatty diets, where you are expected to make this big kind of overall change, and that always has the expectation of an endpoint. And I encourage patients to make changes that they think that they can sustain long term and can become a lifestyle habit. If eating a particular fish that they absolutely hate is not going to work long term, you don't do it. You think about other ways to make up for that. So I begin by tweaking what the person is already eating. So, for example, if they are eating a slice of bread with some jam on it, my tweak would be to ask if they can tolerate eating a whole grain toast, and rather than the jam, how do they feel about putting some sardines on it or a smashed avocado on it. And so it is the slow tweak, and then just testing how that change sits. And then taking it further. And to be honest, this is somewhere where my patients have proved to be far more creative than I could ever be. I still have an Aldi list that one of my patients in Lewisham brought for me, where she brought that. She said, I don't know about all this. This is my shopping list. circle what I should be eating and what I should be not. And I thought that was really brilliant. There's another patient who took pictures of, her shopping basket and asked me, because the whole idea of processed was just too confusing. She almost was in tears when I told her that actually shop-bought bread is highly processed. And, is there ways that you could, add more, could we space out the amount of bread by, including more vegetables? So Mediterranean diet would be my top tip. My second tip, the emergence of the research around the gut microbiome, although the human studies are rather limited, it's now pretty clear that that is how the magic happens. So, if you think about, yes, you do get the nutrients and the phytonutrients from the diet, but I think the magic, the alchemy of the translation into the beneficial effects, it really depends on the gut microbiome. So my second tip for my patients is to think about how we can increase the diversity and increase the quality of their gut microbiome where they are. And the first thing I tell to people that first thing that you have to do is you have to increase your hydration. Because if you're not well hydrated, you will tend to eat or drink things more that might not be beneficial. Lots of cultures do not have that kind of predominance of fermented food. Obviously coming from the Indian subcontinent, we know that, yogurt used to be made daily in every home. There was lots of fermented foods because, so many grains were used for easing digestion. So that is the bit I will slowly kind of introduce and tweak, and we begin from increasing the prebiotics. And again, which comes back to vegetables and whole grains, how do you increase the food that the healthy bacteria have to eat before introducing the healthy bacteria, because otherwise they're just going to starve or they're going to be outspaced by the unhealthy bacteria if your food intake is not proper. But really, Suraj, I think this is a very personalized approach. I find, which is what, keeps me interested, that no two patients are the same. I find that, if you meet them where they are, I can never prepare for this with a patient, because what they bring in, the questions that they have, I hear about a new fad diet almost every month, and then I look it up and I try to understand the logic. But similarly about food, patients are very interested in this. They will go and research and bring things that they are learning and their questions, and then they bring their own experience. I have had patients who have had conditions where they can't tolerate many of the things that I'm asking to eat. And then we go down the more specialist diet where I will bring other people in, because I know my limitation as, more kind of a general practitioner when it comes to nutrition. So we are more thinking about specialized diets for SIBO or for IBS, like the FODMAP, etc. And so, yeah. So those would be my few tips. But I would say, go with the patient, let them lead it, see where they are willing to trial the first change.
No, that's fantastic advice. Thank you so much, Pratima. It's been really wonderful.
Thank you so much, Suraj, for having me. And, I would just like to leave the audience with a reminder that, many of the things that we do and our patients do are optional, but everybody eats. Yeah, everybody eats. It's enjoyable. It is meaningful. It improves health. It improves well-being. And I hope that we will keep our curiosity and creativity open.